So Dr. Ashutosh will join any moment, and in the meantime, all of you are they able to put comments?
No, sir. That is also
Okay.
we have muted.
Okay.
We'll open the
You
comment
can
section after the session at the end.
oh, okay. Okay. Yeah. So that they can, yeah. Or you can do it this way. You can allow it for the up to the moment the introduction starts, and after that close it, and then again start it again during the end. Okay.
Okay.
Yeah. So that they can introduce themselves. They can say hi, hello, whatever
Okay.
they
The
want.
chat box is open now, everyone.
Okay. Okay, so the chat box is open, so please feel free to introduce yourself to each other and to us so that we get to know you. Okay, because people from all over the world are attending the meeting right now, and so that is good. Okay, I don't know, some stranger is calling my number, I don't know. Anyways, so and when you send the message, send it to everyone, not to the host and panelists. Okay, okay, Sunny Anand from India, that's good. Okay. Today has been a very good day for me because I finally got the sleep that I really wanted the past 1 month. So I really don't know who on earth is this person that is calling me and why. Hmm? Okay. Okay, Marwa B Farm graduate Bangladesh. Excellent, excellent. Yeah. Okay, Akanksha, good evening everyone. Okay. Yeah. Priyanka Priyadarshini Patnaik from Bhubaneswar, India. Okay, excellent. Good. Chandri Madas from India, group number 14. Morsid Alam Khan from Bangladesh. Maruf Rehman from Bangladesh. Shikhani in South Africa, public health researcher. Anfal Rehman from Bangladesh. Dr. Kalkidan from Ethiopia. Excellent. Professor, okay. Portia is saying, hi, Professor and colleagues. I'm Portia Manangajira from Zimbabwe. Okay, excellent. Welcome. Santa Kumar Adrios from India. Sheikh Chand from India. Dr. Ashraf Lakho from APTP Pakistan. Welcome. Sumaya Basar Dola from Bangladesh. Arifa Jannat from Bangladesh. Okay, Dr. Ashutosh hasn't joined yet. Okay, let him join. He has been already sent the link, so he should not have any issue at all. I've sent him on WhatsApp as well. Means he's communicating to me, so not an issue. He may be making some last minute preparation.
Yeah.
So,
I just
okay,
joined.
Iman, he has joined? Yeah,
Yeah.
okay. Okay. Yeah, that's good. That's very good. So you can spotlight him. Yeah. Okay. Hi, Ashutosh. How are you?
Hello,
Hey,
can you
hi,
hear me?
hi. Yes, I can hear you very well. Yes. Okay. Good to see you after so many months. Okay.
Yeah.
So we'll just start in a few minutes. Let the participants start joining. Uh, so we have people from all over the world. We have 850 plus people for the Global Advanced Certificate Program, and then we have more than 300 people for the workshop series, international workshop series. So about 1,000 plus people. But
Yeah. Wow.
let's see how many people join live because most people are based in different parts of the world, so it's asynchronous. So it will be all recorded
Yeah.
and streamed on the YouTube as well, so they can watch it later.
Yeah. Wow.
Okay.
Yeah. So I didn't know. So I would have prepared a bit. If I had more time, then I would have prepared like much better presentation, and I would have
No
given
worries.
more deeper. Yeah.
It's going to
So
be
I
it's going
thought
to
like
be
it's just for
interactive.
the students.
No, it's not students. People from all over the world and all stages of career are here. So, but
Yeah.
a lot of people are quite young. That's true. Okay, so Songile Chiane from
Yeah.
South Africa, excellent. Namadi from Nigeria, Saida Nosim Nasita from Bangladesh, Faujiya from Kenya, Dr. Mahmoud bin Aziz from Bangladesh, working group 2, Baba Boya from Benin, Dr. Priyanka Gulik from Pune, Maharashtra, okay, Najmun
Wow.
Savada Mera Hinu, okay, and Najmi from Bangladesh. Hi, Najmi. Yes, Hassan Majidi. I think it will be a great session. It is going to be an excellent session. You know, you have an excellent speaker. He has already joined, and I am all here to moderate the session. Yeah, looking forward to hear from you. So, yeah, Faisal, please remind them that to join as soon as possible. There is no seat limit. We have 500 seats, you know, so there is no seat limit. Should not be an issue tonight. Okay, everyone should join as soon as possible. All the group leaders who are listening to me, please remind in your groups and to your group mates that there is no dearth of seats tonight. We have 500 seats on Zoom. We have premium Zoom, so no issues at all. We are rich now. We are no longer poor. So we can have our session as is done
Okay,
on any
can I?
internet. Sorry, you want to say something?
Yeah, no, I'm just like finishing up some of the slides, so I will join back in 5 minutes.
Yeah.
Is that okay? Like I'm here. I'm not like
No, you
gone.
please stay.
Just
Yeah.
yeah.
That's fine.
Just
Yeah, sure.
turning off my video.
Please take your time. No worries. Thank you.
Yeah.
South Persian Chehara from Mumbai, India. Oh, you have people from everywhere, actually. Lots of people. It's growing, but please be fast because our Sachin Boria from Uttarakhand. Excellent, Sachin. You need to be more active, beta. You need to talk to me personally. You need to give me a call. We need to discuss. Okay. And if you're able to hear me, Ariful Islam from Bangladesh, Dr. Deni Matthew from India, iPhone. Who is this iPhone? Saying good afternoon to all. Ismail Yemer from Ethiopia. Okay, Dr. Dina from Mumbai. Ali from Republic of Somalia. Excellent. Wow. Jainab from Tanzania. And then we have Subhangini Kushwa from India. Then we have, it's just going down very quickly. Okay, Vishal Kumar Patwa from India. Okay. Nadia Campbell from Jamaica. Okay, hi. Welcome. And that's good. You have everyone literally. Kavita Chandra from India, Jharkhand, Deoghar, Ems. Okay, Jobair from Bangladesh. Hi, Jobair. You need to be more active, Jobair. Okay, you need to talk to me personally, beta. Mamadu's camera from Gambia. Okay, welcome everyone. Nadia Campbell from Jamaica. Semkura Tugume from Uganda. Excellent, welcome. Arindam Vishwas from India. Okay, nice. Ashley Dubey from Malawi. Okay, yeah, my language is English, definitely. Suhanur Rahman from Bangladesh. Cyprus from, Cyrus from Botswana. Okay, right. Okay, hi Cyrus. Okay. Ananya Ghosh from, is saying, Ananya Ghosh from India. Okay. Mamadu's camera from the Gambia, and Dr. Kanimoji from India. Hi, Dr. Kanimoji. Nonpan Scott from Cameroon. Wow, wonderful. We have people from literally so many countries. So those who are listening to us on YouTube or any other platform, for all posturities, they should know that we have literally participants from all over the world right now. So it's very, very heartwarming to see that people are very participatory. They're coming forward on a Saturday evening. And this training is going to be very special because Dr. Ashutosh is an excellent expert on health economics outcome research, and also a trained statistician, a data scientist. So I think you're going to learn very, very many interesting things. Obviously, besides the benefit and reward of getting a certificate, what is more important is learning. And I think that's very, very important. Okay. Yeah. Faisal, please post that when you're posting the reminder that there is no seat limit. Okay, you can come and join. We have 500 seats. So unlike the previous time, we do not have that limit anymore. We have 500 seats. They should be happy to come and join live. Because sometimes they fear that they will not get the seat. Last time they had faced some issues on Teams. Sachidanand Jha from India. Okay. N. Kulada from India, Amal from India, Yusha from Bangladesh, Shifan from Ethiopia, Dr. Leelapati from Chennai, Atul from India. How long will this session run? The session starts at 7 o'clock sharp Indian Standard Time, and it will run till the moment our professor can speak and you are willing to learn. So if you are willing to learn, you are welcome. If not, please go and have a sip of coffee, enjoy your brownie, and take rest. Thank you. Hello, sir, Dr. Devajyoti Sikdar. Okay, Dr. RC from India. Thank you. I'm happy to be on your platform. Nadia Campbell is saying excellent, excellent. Welcome, all of you. Radeep Mitra is saying good evening. Radeep Mitra from Bangladesh. Okay. Gammel from Bangladesh. There are so many people. Yash Nigam from Lucknow. Siti from India. Sunny from University of Allahabad. Okay. R. Mohan Rao from India. Ashraf from APTP Pakistan. Dr. Noreen from Bangladesh. Sir, how is your health today? My health is doing very well. As you can see on my smiling face, glowing face, I think I'm doing well, and I'll be happier if everyone joins, because we have arranged the Zoom premium gym with a lot of difficulty. So please come on board. We have no sitting limits. We have 500 attendee sitting, which is very high premium. Okay, so please come and join. Hello, Prof. and everyone. Dr. Farjana Munmun from South Korea. Okay, hi, Farjana. Okay, sir looks very energetic. Definitely. I am looking energetic, and I'm feeling energetic, and I'll be happier when you join and enjoy learning, hopefully. Okay. Alsana Shishe from Gambia. Okay, that is good. And Dr. Bashma Hossein Toiba is saying good evening, everyone from Egypt. Okay, hi, Bashma. And then we have someone named. I cannot read it, but it's saying Ayodeji Arugo from Nigeria. Yes, Jannatul, the bigger meetings will be all held on Zoom, so there is no sitting limits. We have 500 seats, so all the program participants can be accommodated very effectively without any more difficulty. Okay. So all of you will have a gala time learning, and will get to also experience the best quality of experience as done on international stage. So Priti is from Chennai. Okay. If I have skipped anything unknowingly, because it's just going down very quickly, okay, so that's why. But thank you. Keep putting, from where you are, what you do, what's your background like, etc. You can put all that in the chat. Okay, we'll soon close the chat. The session will begin just now, Babika. Please stay on board. Okay, our analyst is just gearing up. So it is a very early morning in US. So he's joining the meeting for all of you. I have the love for teaching. So hopefully you will enjoy the learning experience as he starts teaching. And it's going to be a very, very fabulous training session. I am very much eager to learn as well. And, okay. Ananya Ghosh from India. Okay. Ashley. Dr. Ogbere Stephen, FSCP, internal medicine physician from Nigeria. Okay, hi, Dr. Ogbere, welcome. Dr. Humaira Khan from Bangladesh. Okay, hi, Humaira. Yeah, please ask all your friends, group leaders, if you're listening, please ask all your friends to join as soon as possible, because we'll start any moment from now without wasting any more time. We are already 7 o'clock Indian Standard Time. So, Ashutosh, are we ready? Can we start now?
Yes, we can.
Okay, great. So, Faisal, the admin, please do the news. Thank you.
Sure, sir. Okay. Good evening, everyone. A very warm welcome to all of you joining us today for another insightful session of the Global Advanced Certification Program on strategic research, collaboration and communication for emerging researchers, and the International Workshop Series, jointly organized by the Global Consortium of Global Health Actors, Leaders, and Thinkers, and Bangladesh Institute of Innovative Health Research. This initiative is dedicated to building a new generation of research leaders. And today, we are delighted to continue our journey with a deep dive into one of the most critical areas of contemporary health research, health economics and outcome research. It is our distinct honor to welcome today's speaker, Dr. Ashutosh Kumar. Dr. Kumar holds a PhD, MS in statistics, and has a strong portfolio of work focused on policy-oriented economic evaluation health systems. Before we begin, just a few housekeeping notes for the participants. Use the Q&A session for all of your questions that arise during the session, and you can also put your questions in the Q&A part of Zoom. Also, your attendance will be counted and the form will be shared briefly during the session. Please fill it within the time limit to receive your certificate of attendance. Our today's session of Methods in Health Research and Ethics will be moderated by Professor Maheshwar Satpathy. Professor Satpathy is a world-renowned leader in One Health, global health, planetary health, brain and mental health, and lots more. He is a much sought-after expert in epidemiology, health emergencies and implementation science, and health innovation using the power of emerging and futuristic technologies such as AI, machine learning, LLM, and generative AI, and geospatial information systems and technologies, and remote sensing. Professor Satpathy has a humble age index of 78 and cumulative citations over 153,000 plus. He has published extensively 285 plus peer-reviewed scientific journals and book chapters of global repute, notably in Nature, Science, The Lancet, NEJM, JAMA, BMJ, etc. Professor Satpathy is currently a research fellow, research professor at the Institute for Global Health and UCL, Global Business School for Health of University College London, UK, and also is a substantive faculty member at Utkal University, Bhubaneswar, India. He is the director and lead of Center of Excellence in Environment, Climate Change and Public Health and Policy, a joint initiative of Government of India and Odisha since 2023. In addition, he is also coordinating the Center of Excellence in Governance and Public Policy. We now begin our today's session on methods in health research and ethics. We will move to our moderator, Professor Satpathy, to introduce our eminent guest today and begin the session. Professor Satpathy, over to you.
Okay, thank you, Faisal, for such a generous introduction. So, welcome everyone. I hope you are having a great time. Good evening, everyone. From good evening, good morning, good night, or whatever time zones you are in right now. Okay, we are having 7-8 p.m. Indian Standard Time here. Okay, so this is good evening for me. So, welcome everyone. I hope you are having a good time. So, we are all good to go now. So let me introduce, this is my honor as well as privilege to introduce my dearest friend, Dr. Ashutosh Kumar, who is currently employed as a Senior Associate in Economic and Valuation Services, EVS, at KPMG US, based in Atlanta, Georgia. Prior to joining KPMG US, Dr. Kumar served as Health Services and Systems Researcher and as a Prevention Effectiveness Fellow at the Center for Disease Control and Prevention, CDC, in Atlanta. During his tenure at the CDC, he contributed to both the Division for Heart Disease and Stroke Prevention and the Division of Nutrition, Physical Activity and Obesity at the DNPAO. Dr. Kumar earned his PhD in economics and an MS in statistics from Washington State University, USA. In addition, he holds an MS in agriculture and resource economics from the University of Arizona and an MA in economics from the University of Delhi, India. His research interests focus on healthcare economics and policy, particularly the application of statistical and econometric methods to examine their impact on various health outcomes. Dr. Kumar enjoys using methods and tools from economics, statistics, and data science to investigate insightful research questions in health economics and health services research. In his free time, Dr. Kumar also loves hiking, trying out new breweries, and watching the game of cricket, which in fact most Indians love. And I think he just shares the same trait, and visiting museums as well. So he is an avid cultural sort of tourist, you can say, and connoisseur, and exploring new places. He loves going to new places, and I keep seeing his new pictures, food and culture. So everything that he says on social media, I keep seeing that, and I feel very happy. And obviously, he's not going to talk about new places here. Today, he is going to teach you about statistics and health economics. Okay, so hopefully, we will have fun time listening to him, learning about all the things that he has to offer. It's been quite difficult for us to get him on board, but we are very happy and privileged to host him. And I look forward to listening to all the wisdom that he has to offer to all of you. And I'm very sure this session is going to be a great one. By the end of the session, all of you would go back home with a lot of learning, which and not just learning, but the skills which you will be able to use in your own research. You do the projects during our global advanced certification program, or even in your personal research at home. Okay, so that's all from my side. I welcome Dr. Ashutosh Kumar to take charge, and the floor is all yours. Please use the time to train them very, very well. Thank you.
Thank you. Thank you so much, Dr. Satpathy, and thank you so much for all the organizers in making this happen. I'm gonna share my screen and then let me just figure it out. I think this one, right? Yes. Yeah. Share. So all you guys can see my presentation. I think I shared the wrong screen. Can you see my presentation right now, right? Or no?
We are seeing your window, sir, not the presentation. Now your presentation will be seen.
Okay, you can, right?
Yes, sir.
Good. That was okay. So slideshow. Oh, picnic. It's not the. Can you see my presentation now, or is it still? Can you see the slide? Maybe I should have just. Okay.
No worries.
Yeah. So I don't know how the Zoom environment works with presentations sharing. So I'm just figuring it out.
Yeah. No, even I'm new to Zoom, like running it. So that's why we have the efficient King Faisal with us, the admin. So he does everything. He is very tech savvy. The generation Z is very tech savvy. I'm not. I'm a just poor old millennial.
Yeah. All right. So I don't know what's happening. So let me just from the desktop. I tried to convert the file to PDF because what happens is that when you share the screen,
The PPT doesn't show very.
yeah, PPT does not exactly. That's the problem, ma'am.
The problem is not from your side. The problem is from the PPT side. Honestly. It's a technical issue.
Yeah. So let me slideshow from beginning. So what I did is that I started my slideshow and now I will share the presentation screen so that you guys will see now. Okay. So sorry about this. I should probably have done this before.
No worries. No worries. Please take it.
screen share. I think. Now, can you see the screen?
It's coming up. Yeah, now we can see it very well.
Very well,
Okay,
right?
so yes, floor is all yours.
All right.
Please
So,
take it over.
yeah. So if I am looking at someplace else, then just don't mind. But I'm trying to see the screen where you can see me in front of you. So, but yeah, I thank you everyone for coming in this presentation, and I really appreciate it. And again, thank you to Dr. Satpathy and all the organizers for organizing it. Thank you so much for coming. Today, I'm going to talk about a topic which is dear to my heart. Um, is that healthcare cost estimation, in which healthcare cost is your dependent variable. So I'm assuming here the audience have some statistical backgrounds, and since Dr. Satpathy told me that go a little bit advanced, so it's in between. It's not fully advanced, but it's also not fully introductory. So it's in between. So it assumes that you have at least undergrad level of statistics and econometrics. So that's what I try to capture. And you know, I come from an econ background. Thank you so much for the introduction. I have a PhD in econ economics, and I also have a master's in stats from here, Washington State University. And please feel free to interrupt me anywhere if you have any questions, any clarifying part, because this this presentation is made for training purpose, not for like showing something unique or some research. So I thought that the audience would be more students. So that's how it is. All right. So before we go further, the disclaimer is that this presentation is actually solely for training purpose. It does not represent views of my current employer or previous employing organizations. These are completely views are of my own, and these are my own research. So before we begin, I believe most of you are aware of healthcare costs. You know, how does it happen? Since we have 1 hour, so I'm gonna like take some time and explain um, the methods and topics a bit more in detail. So you visit a healthcare center, either it be a clinic or a hospital. You are gonna accrue some kind of cost, and you're gonna pay for it, pay for the visit. But what happens is that as a researcher or as a data scientist or as an analyst, when you are looking at any kind of healthcare cost, you would find that there are some people who are who have insurance but never visited clinic even once. Some people who visited clinic few times and had $5, $10, convert the dollars to rupees in your own currency if it's a global audience. And some people who have had like 100,000 kind of bill for the whole year. So when we see a data set coming from the clinic and hospitals and all the medical centers, we find that we have population, for example, say adult population 18 to 64, you would find those cases in which there are some healthcare costs which are on full year. They don't have like $100 even expense, but there are some people who have $100,000. So when you are trying to analyze, for example, you want to know the cost of any condition. I particularly have worked on two medical conditions that I primarily have worked on, which is obesity and hypertension, for example, high blood pressure. You would find a healthcare cost when you put this as a dependent variable. There are some issues in analyzing those kinds of costs. Why? Because it's skewed by rare but extremely high cost events. Because there are some people who are going to get a lot of who are probably very sick. They visit very often, and there are some people who don't go anywhere. Like they are healthy. They don't visit in full year. They don't have to visit the clinic. Then you would find so what you will have when you will take a histogram of healthcare cost, you will find that at zero cost there are hundreds and hundreds of people who have no cost, and then you would find some people who are $1,000, $20,000, those kinds of people. There are high frequency of those kind of patients. So you have a skewed data and you want to analyze, and 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 then there are some kind of problems, statistical problems, which we are going to talk about in this talk. And that's one of the core thing that healthcare economists do. Cost estimation is one of the first thing. And in fact, cost estimations are very valuable for any kind of knowing the effect of intervention. So, and that's why healthcare costs are important to analyze. So that's the background of this talk, that we want to know the cost of any condition. And we want to know the cost because it's very important to know how much this condition costs, so that if you come up with any policy, if you come up with any intervention that you think is going to help for that condition, you first want to know that how much does this condition cost. And then you will develop a policy, and then you will know, okay, I developed this policy. I know for sure that this policy is probably going to save these costs. This policy is going to work to avoid these kinds of disease cases, these kinds of medical events, so that people can save these costs. And saving these costs are good for both government and people and healthcare clinics, because saving costs is important. So this is the whole background theme of this talk, and this is a bit more statistical than healthcare, since Dr. Satpathy told me that this is more for advanced stat and that kind of thing. So I would just go and discuss the stats more, less medical economics and less healthcare. All right. So yeah, these are the four features of healthcare cost data that you will get. You will find that there are a lot of zero cost. It's very skewed. Cost cannot be negative. It can never happen that you go to a clinic and you come up with negative payment. Like, clinic does not pay you to visit the clinic. So it will never be negative. You will find no negative values. You will find variance varies of a healthcare cost depending on what kind of independent variable you put on the right side. So many a times in the talk, I will discuss left side and right side. It means the regression equation. So I believe that you all are aware of regression equation. When we have a regression, economic regression or econometric regression or statistical regression, linear regression, basic, uh, we have a dependent variable that we want to estimate, which goes in the left side. And we have independent variables that we want to use as explanatory variables. They are called explanatory variables or independent variables that are on the right side. And those are the terms I will be using throughout this presentation to explain. So generally, variance of the cost vary with independent variables. So for example, if you're doing the cost analysis, your dependent variable is healthcare cost. And your independent variables would be sex, what kind of male, female were they visiting, age group, those can be there, disease conditions, other disease conditions can be there, and major condition that you want to know. For example, you want to know the cost of hypertension, high blood pressure. That there would be one condition for that in your independent variable. So when I'm saying in the slide independent variable, you have sex, age group, disease conditions, those things, which you want to know the effect of those things on your healthcare cost, which is on the left side, which is your regression equation. All right, so that was the first slide. And now I'm going to move right into statistical methods. As I said, this is more about more stats and more stats and econ and less healthcare. So I assume everybody knows what OLS is. Ordinary least square, which is your plain vanilla, regression that we call linear regression, that you study in your, econ undergrad or stats undergrad, in which you do the OLS regression, in which you have the raw cost, which is actual cost data, cost variable, independent variable on the left side. But when you try to do the OLS on cost data set, you will have some issues. You just can't run regression and say, hey, I did it. And, I estimated the cost of this. And now these are the estimates I have. Why? Because the OLS, as you might recall, they have their certain assumptions. And OLS first, for the reasons I told before, like some people, it's very skewed. Some people don't visit, some people visit to the clinic. So you have the dependent variable can be non-normal. So the main reason for regression is that you assume normality of errors. So your errors will not be normal. It's likely not be normal. And you can even, OLS sometimes does predict negative cause. So when you do that, you know, when you do the OLS with the cost data. Some people, what they have done when they struggle with this kind of estimation, what they did is that since the costs are very skewed, so instead of taking the raw cost, they transformed the raw cost variable into a log method, and they did the log transformation of the cost. Well, if you are doing some kind of analysis, and if you have done the log transformation, you know that mathematically it's not very different. It gives you the same interpretation in a way, except that you will have to then change the log to non-log when you are interpreting. But it has its own, because when you study the maths, you know that you can take the log transformation because it's a monotonic transformation. It keeps the feature of your variable, which is the cost data, very much intact. So by taking the log, which some papers have done, some research papers you would study when they estimated the cost, by taking the log, you would find that log cost generally will be normally distributed. So your distribution will be normal. And you can use OLS in that case when you take the log. But it has its own limitations also. It does do the job for you, but can have some problem. For example, when you estimate the log cost, and you will find say, for example, obesity, you want to know the cost of obesity. So you have log cost in your left-hand side, which is your dependent variable, and obesity on the right-hand side. So your outcome when you will interpret the model, you will say the log cost, change in log cost because of obesity was this. And then what you will have to do, you will have to convert the log to back to non-log. So you have to again retransform to make some sense of the dollar values that you get for the particular condition. So that's the limitation. Many a times, the biggest limitation of log cost is that you can take log of zero. Log of zero is undefined, and there have been hundreds and thousands of people who are in your sample who had healthcare insurance. They could very well visit healthcare clinic, but they had zero cost. And you'd have to drop their variables, you'd have to drop everything. So many times you will not be able to model them. So those people who were basically healthy, they never needed healthcare, they are not in your sample. If you're doing the log cost, you'd extract. And so these are OLS. You are still doing OLS, but doing with log cost helps you a little bit. It doesn't help you as much. And again, here with log cost, you also assume the variance of error is constant. So, so what we basically discussed right now is just like, current theme background of this talk is mainly two things. It can go more advanced, but I did not go too much advanced, like basic. I will start with basic, like, um, how to model the cost. I'll give some codes also. And so first we will discuss what is heteroscedasticity. I believe most of you are aware of it, but I will still a little bit give you some insight about it. And and then we will discuss what should be done when there are a lot of zero values. And then I will discuss two examples of my papers that I got published recently, which you can go and read and let me know what we have done. So I have gone two examples I will give from two papers that I published, and I know in those papers you can, if you come up with any questions or anything, I can help you with that. So let's first discuss heteroscedasticity. So heteroscedasticity is plain standard, like in your undergrad econ or undergrad stats, as I said, you'd know that it changes. The variance depends on your x. X So y is your outcome, which is on the left side, which is cost. X is your independent variables, which is your, the variables that you want to use to predict the cost. So many times heteroscedasticity is a problem because the normal regression equation that we know, which is called linear regression, multiple linear regression, which is ordinary least square, it's called. Um, we assume homoscedasticity. It means the variance when you predict, for example, uh, when you're trying to predict, here the example is income increases with age. So for example, you want to predict the age and income is on the left side and age in the right side. You would find that higher the age is, the higher the income is. So so your variables dependence to the cost and between themselves also is not, uh, the errors have a pattern. Errors do not have they are not random. If errors were completely random, and then you can say the variance is homoscedasticity, like the variance is identical. So here I'll give you an example of identical variance. Here you have predicted something, and you found that your errors are throughout around zero for all the values of uh, your independent variable. So so this is there is no pattern, nothing. You can see the errors are around zero, and this is a good case. This is ideal case you want. But that does not happen when you have a cost analysis. And for example, if you regress cost with age, and you'd assume that errors would be like, homoscedasticity. So when you do that regression, on the left side you have cost, right side you have age, you know that your errors will not be homoscedasticity. Why? Because as we age, like age and income are correlated, in the same way age and healthcare costs are also kind of correlated. And you'd find that higher the age is, because you know the as we age, we have more sickness, we have more conditions, we have more problems. So higher the age is, your variance will also change. So because of those cases, your homoscedasticity, it means the constant error variance, that will change. So so you actually want this to happen, in which your errors are same throughout your age, in your sample, but that does not happen. You will find that your errors are very small in the beginning, at lower age group, or age was just an example. It could be possible that there are other variables that you have included in your model in the right side, uh, in which the errors are not exactly random or constant variance, we call it identical constant variance, which is a very fundamental assumption of OLS. Um, but when you estimate those kinds of models, you'd find that your errors for cost regression will not be constant. Um, it's not homoscedasticity. Homoscedasticity is the constant variance. Heteroscedasticity is, like these kinds of errors. So you don't want this kind of case, but it happens when you estimate the cost. As you can see, at lower values here, surround errors are zero, but as your value increases, errors are, everywhere, spread out. So it's increasing, it's not constant. So you don't want this. So now one would say, okay, I know errors are not homoscedasticity is not there. Its assumption is not homoscedasticity assumption is violated. Why do we care about it? Well, we care about it because most of the OLS models predictions on uh, homoscedastic model is important, because you can, if you do not use that assumption, if you relax that assumption, your estimate that you will get, for example, you would say obesity costs this much. The value that you will get, it will be biased. It will not be true. That's just the simple mathematical thing about this kind of modeling. And any kind of, when we are assuming that you have taken the log cost as your dependent variable. So you got the cost variable, then you took the log of it, and then you ran that regression. Uh, But when you did the regression was fine because you were able to get the normal errors, but you were not able to get the homoscedasticity, even with the log cost. Because the moment you will convert the log to non-log to get the dollar value, that would assume you need to have homoscedastic errors. So that's also important. So you do need homoscedasticity even with the log model. Um, so when the predicted cost, when the error is heteroscedastic, can be when you predict the cost with the heteroscedastic error, it it becomes like very like the bias could be very big. So for example, when you estimate the model, it is possible that the cost estimate that you got, you know, they are very different from actually they should be. So your model is picking up a lot of errors and you don't want to report those kinds of models. So that's why homoscedasticity is needed. So what should be done about it? So you have a heteroscedastic model and you want homoscedasticity and you want to estimate your cost. Cost is your dependent variable. What would you do? Of course, you would not be able to use the OLS. Even first choice, you had to use the OLS on raw cost, which is not even normal, not even constant variance. Um, and when you took the log, you got the normality covered, but you still could not get the uh, constant variance covered, which is homoscedasticity covered. You still violated homoscedasticity assumption. And that's where this GLM model comes into picture. If you guys have ever worked with GLM models, it's a kind of OLS. You can model OLS inside GLM based on your link function and variance function. I am not gonna go in detail, mathematical details of GLM. GLM are generalized linear models, and they have generally known for a link function and a variance function. So you have now in the OLS, you did not have those kinds of things. OLS is one case of GLM, basically. The common linear regression that you study, it's one case of GLM. So what happens in GLM, eh, I will give you an example of GLM and OLS. OLS is your normal regression, and that will be on the next slide. But here I'm going to explain you how GLM works in this. So you have a link function, G is your link function. So when you do a regression, you do not do, can you see my pointer? This, right? Okay. So my mouse, if you guys can see, you can see that G function outside is not there in OLS when you do the normal regression. This is not there. In OLS, you just do expectation of y given x. And this is where this is your intercept variable, and these are your independent variable that I was calling as sex, age group, or any kind of disease condition that you put in the right side. So this is the right side of your equation. Here you can put anything, age, sex, and whatever. And in the left side, this is your cost variable. And this is what you model, expectation of cost given X. You model in the normal OLS. You do not have this red part G. But when you do the GLM, you consider this also as a function, which you decide which function to choose. And you model, instead of modeling expectation of y given x, you model g of expectation of y given x. And this g function, you decide which one you choose. And everything else, is same. So, and this we call as the link function. This g is the link function. And link function, here you have multiple option of either choosing link as a natural log. So if you took the log of this, you can take the log also. You can take a square root. You can take any other function, link. For example, if you take the log link, it will be log expectation of y given x, alpha plus beta x. So if you had a little bit of calculus in your, I'm going to give some description for those people who did not, Dr. Satpathy, so I just want to know, most of the people here had some kind of statistic, um, undergrad calculus or stats in the audience, then I would not go in much in detail.
Uh, Ashutosh, most of the students or participants here are science students, but some of them are also from social sciences and humanities, and some of them are like purely medical, so they may not be comfortable in terms of mathematics. So maybe just run through the basics as well for them so that they feel more comfortable with everything.
Yes. So that's why. So those people who already know, don't feel offended. That's not for you, if you know. But those people who don't know, I will just give you a basic, basic description that when you take the log, when your dependent variable has a log in it, and when you try to estimate this kind of model, it gives you a percent change in y for a unit change in x. This is an important point because, and it where it comes from, if you had undergrad calculus or even 12th high school level of maths, when you take a derivative of log x, uh, derivative of log x is 1 over x. The derivative of log anything is 1 over x. Derivative of log x is 1 over x. And when you try to estimate this model, uh, basically it gives you the percent change. So what it tells, the intuition is that um, you change x, 1 unit of x, your beta variable, the beta variable here gives you description that if you change 1 unit of x, uh, you will get percentage change in y, given that when you estimate, when you estimate this beta, you will find that it gives you percentage change instead of actual change in value of your y. So that's what it is. So now we will go through a little bit of GLM and OLS. What's the difference? So when you do the OLS, for example, you remember that we have stopped doing OLS expectation of direct y over x, because there were two error problem with that kind of model. Normality was violated, and homoscedasticity was violated. So we started doing expectation of log y of x in OLS. In this model also, there was violation of homoscedasticity that we discussed in slide 4 or 5. But when you do the GLM, instead of log being inside expectation, what you are doing in GLM, your log is outside, so you get expectation of y over x, and then your log is your link function. So log of expectation of y of given x, and in OLS, when you did, in which you did log of y over x, and then you get the expectation. So this is your standard regression equation, hop 1, in which your cost is taken in the log form, and then you run the linear regression. What you do in GLM, you don't do that. Uh, you first take the expectation. Basically, you take the linear regression first, kind of aspect, and then you take the log. So this is the common basic difference between your GLM and OLS. Uh, Other people who are very deep into this and they want to know more about GLM, they can go deep. As I said, paper is there. This paper was one of the very famous paper, and kind of set the model, set the precedence. Now all cost estimations happen only through GLM. Nobody uses OLS with log. So this model nobody uses anymore because of its problems, as we discussed. GLM, main advantage with GLM is that dependent variable can be 0. You don't have to do retransformation. You don't have to do the log uh, to delog. So when you take the log of cost variable and you estimate the model, and when you take out the log, for example, if you take the log of $10, say the cost. So log 10, if the base is 10, would be 1, right? So log 10 base 10 is 1. And so the 1, you model your whole equation based on that 1 because you took the log of that. And then when you want to report it to some agency, you can't say that cost was in log form. You have to delog it to report in dollar value. You cannot say that, hey, you had this intervention and it saved you log $20 or it saved you log 20 rupees. right? You have to convert it back. So that was the major disadvantage of log model. And for to convert it back, people use a smearing estimator to get log 10 back to dollar value or rupee value. But in GLM, you don't have to do that. It's inbuilt in your modeling, so you don't have to do that. And it does not assume homoscedastic errors. In GLM, so if you have done a little bit of data or if you've done a little bit of SAS, we take care of heteroscedasticity, those errors that we discussed by using robust, command in Stata. I have not done much regression in SAS, but in SAS also there is a way of doing it but here in GLM, you don't have to worry about heteroscedasticity. This model uh, does not assume homoscedastic errors. Like this is okay. This model is okay if your dependent variables have different error terms. Like if it's age, it's different, and income. So this is the major advantage of GLM. So GLM does not assume constant variance. So homoscedasticity is another way of saying constant variance. Variance, when we talk, variance is in your error terms. When you model Y and X, there are always some error terms. And if you have regression in your mind, then you would find that when we model Y over X, there are few things that our model is unable to pick up because it's never, you cannot get the best model uh, every time. There would be something that you are unable to pick up, the effect of some factors, and that you have not included in your model, and that's where the errors are. But the GLM does not assume constant variance. GLM assumes there is a function that explains the relationship between the variance and mean, and it assumes that there is a relationship between the variance and mean. So it's already inbuilt in GLM, which was not there in OLS. So how we do it in GLM? So first part, we understood here that GLM has a link function, this link function, ln, the log. And the link can be anything. Like you don't have to choose only log. Log was just an example. You can take other link function also. GLM, other component of GLM is that it has a variance function in which you can choose multiple distributions in your case. Um, in OLS, if you remember, we assumed that your errors were normal, right? Normal means errors followed normal distribution, statistical distribution. But GLM works with gamma distribution, Poisson distribution, gamma distribution in which variance is proportional to the square of the mean. This is most common. Many a times I personally have modeled healthcare cost, and I have found that it comes down to gamma distribution. Most of the time, this is mostly used model. So if you read any paper of healthcare cost, you will find they use GLM with gamma distribution and log link. So this is most common. Poisson is also there. Poisson has a strict, sometimes we use Poisson also. It has a strict condition that variance is proportional to the mean. Many times it's almost very same, like variance is mean. If you go to the hardcore Poisson assumption, variance and mean are same. So estimation methods, how would you estimate those kinds of models? How to specify log link and gamma distribution and dependent variable? Your dependent variable is cost. Independent variable could be, for example, X1, X2, X3. These are like sex, age group, disease condition. You can keep on putting everything in the right-hand side. So if you do this is what I have done most of my papers. Just do the GLM. This is your cost variable. And these are your dependent variables, independent variables. This is cost, your main cost variable. You don't have to log transform or anything. Whatever is in your data, raw cost variable, you can just use it there. If you wanted to do the linear regression, you had to convert this in a log form because of those issues that we discussed. In GLM, you don't have to do, just take the cost this. And here you mention gamma, family gamma, link log. So if the family gamma, when you are reporting this, it means you are saying that use the gamma distribution modeling assumption. It means errors are not homoscedasticity. Errors are not homoscedastic, constant variance. And you are using the link log that takes care of your queued cost values when you take the link function. So this is how you estimate the GLM model in a state, if you want to do that.
Ashutosh,
Yes.
could I request that could you demonstrate like the uses of these models in some papers, maybe your papers, others' papers, so that because people across here from different diverse backgrounds, it would be good to
Yes.
demonstrate like how it's done.
Yes. So I will. I have not gone detail in. I could do that in the later part of the slide. I have discussed two of my papers. Uh, I did not make presentation about my paper. I gave more methods this presentation. But I will discuss a little bit more about my paper, and I can go in more depth if people need to know.
And we can also
But
give them an opportunity to ask questions in case they have not understood anything later on. Maybe you can
yeah.
clarify.
So far, anybody has any problem that we discussed and did not know or could not understand
Hazel,
any of the slides?
Hazel, can I request you to open the hand function? Those who want to ask questions, they can raise hands, and we can allow them to ask questions.
Yeah,
This is a good time to
the
allow that.
raise hand option is open, and I can see one question is there in the chat box that
Okay.
Vishnu Priya has asked, Sir, can we have a few references that use the regression technique? You are describing a real life case scenario, how to calculate the cost for any given health condition.
Yeah. So um, that's a good question. Had like real life example. What are you looking at? What you are seeing on my screen? I don't know which one it's. Can you see this slide that I have shown, like this paper? Are you able to see this?
We are seeing the slide, sir. GLM variance.
Only slides, right?
Okay, this one, right? Okay. Still the slides, right?
Yeah, sir.
Okay. So I think I'll have to change. So I will give you, I'm gonna discuss the real life example in I think later slides. And then probably I will share the screen instead of the slide later on, in which we will
Yeah.
discuss some examples from, in fact, my papers.
Sure.
And those papers are now, I can even share to the audience. They can go read the paper. And if people have any questions on those papers, since I wrote them, so I can deal with all the questions, and I can even share the codes if people want to know the codes and how to conduct those analysis. So yeah, no problem. So yeah, so I'll get back to this question about the real life example. I'll discuss two papers, and they are both in like one of the top journals. So you can go ahead and read them and understand from them. So okay, so I'll get back to that part. Any other question?
Anyone who wants to ask question, please raise your hands because Dr. Ashutosh may be willing to answer anything. Okay, so you can ask questions right now. We have 5 minutes, and then after that we'll again proceed. Okay, or you can use the Q&A option.
Yeah.
Okay, nobody has raised the hand, so it means we can go ahead. Thank you.
Yeah. So till now it was very basic, and we discussed GLM cost, and this is how you model cost. And some people who use SAS, they can use this method in which you can do some use SAS. I'm not very fond of it, but I have it here.
Okay, there is a
Choice between
question.
GLM. Yeah.
There is a question for you, Asu. Jusu Musa from Sierra Leone is asking, what characteristics of the dependent variable cost suggest the use of a gamma distribution?
Yes, very good question. So the cost, so the gamma distribution, the assumption is that the variance is proportional to the square of the mean. So as we discussed early in the beginning, typically I wish I should have done some public data if I had some public data. That would be more training training in which I would be doing some live, give you some live data examples and show you some of the examples. But I can give you some basic description. When you get the cost variable from the clinic or anywhere, at the national level, if you get, that's better. And when you run basic histogram, you will find that it follows the gamma distribution. So you get the cost variable, do the histogram. It will have a kind of a highly skewed at zero value or less value, and then it will plateaued out, which is a standard gamma distribution. So why it happens? It happens because there are a lot of people. Sorry about it. It happens because there are a lot of people who had very low cost, and they are highly represented in the data set. But we also have few people. So the people with low cost, highly represented in data, but there are few people with very high cost, but not as many represented, but they are also there. So when you kind of modeling it, the peak is there very high at the low cost, and then it plateaus till like end. It goes on till $100,000, because you will have some people who had $100,000 cost also. So when you do the common histogram, this property of the cost data, which is very unique, it's not like standard any kind of dependent variable in which you can just do the regression. This unique
Okay,
property of this cost data makes it gamma distribution suitable.
okay, there are a few more questions for you, Ashu. Sandeep
Yeah.
Jagdale is asking, sir, how is it useful for social sciences?
Yeah, social sciences, exactly. So if you're doing social science, if you're doing any kind of regression, I would say yes, this is a statistics. And if you're doing any kind of regression modeling in any science, material science, social science, um, any kind of science, you would come up with those kinds of data set in which you will have to use GLM.
Definitely.
I cannot tell you what is the other example of data set. Depends on which kind of social science you are in, like psychology, or if you would give me more description, there would
He's
be
in
some cases
sociology.
in which
Sociology. Social.
sociology. So yeah, so in sociology also you do some kind of regression in doing some modeling and some regression, and you would find if you find that the variable, I don't know what kind of research questions you are pursuing, but if you are pursuing some kind of research question, you have a data, and when you run the histogram, and if you find that it's very skewed in one side, this is perfect for you. So this presentation is helping you, because you have any data set that violates the linear regression assumption. This presentation is for you.
Yeah. Then there is another
And
question.
yeah,
That's a very, very basic question, but I think I want you to answer that. Sir, what is ordinal or internal interval variable, and how it's work? Means how does it work?
ordinal variables, ordinal data set, right? Yeah. So very good question. So ordinal data set, if you have, uh, it depends what kind of analysis you are doing. Is your ordinal data set on the left hand side, if you want to model ordinal data set as an outcome, or if you're using ordinal data set as an explanatory variable in the right hand side of the regression equation. So to be specific here, uh, when we model this, you can see my mouse, right? So it's, if your ordinal value data set is on the right hand side, like here, then no worries. You can use the GLM directly. No problem. You will get the model estimates for all the ordinal values. You just put it here as an ordinal variable. You will still model it. But when your ordinal value is there, then you cannot use GLM, kind of, because when your ordinal data is the outcome, and then it's a problem. Then they have different modeling methods. For example, I discussed somebody was from sociology, and many people like study these things, that what are the predictors of happiness, and they use survey data to know the happiness prediction. And happiness data many times are ordinal. And where does it come from? It comes from surveys. If you go in US also, we have a lot of surveys, National Health Interview Survey. In India, in the same way, every country has a survey in which they ask people right now how happy you are or how healthy you are. And then people answer in good, better, very good, very healthy, and that's an ordinal, right? So it has a scale, and you will have when you will try to model those kinds of outcomes, they will have different modeling. Ordinal data has separate feature. Uh, this type of that is not a cost outcome. Like it is ordinal. Some people use ordinal logistic regression. Some people there are multiple. They have different varieties. So it's not applicable here. To just answer your question.
Okay. Okay. There is one last question before you resume. Alasana Shise is asking, how does heteroscedasticity affect the validity of cost-effectiveness estimates in health economic evaluations, and what are the most robust methods to detect and correct it in real-world outcome data?
Yeah. So heteroscedasticity in CEA, cost effectiveness analysis, right? They're asking. So the cost effectiveness analysis is a different ballgame. Um, there we estimate del C divided by del E, which is delta cost divided by delta um, effect, like whatever the change. And this lecture is not on cost effect. I can give separate one on CEA. Cost effectiveness analysis is a completely different method. Only thing that we take from here in cost effectiveness analysis is the cost estimation. You can say the cost estimation helps in cost effectiveness analysis when we do, because you can say that you have some intervention, and you can say that because of these interventions policy, you saved this much cost. And that's where you will cite this paper and say that these were the costs that were saved because of that intervention. Heteroscedasticity, since their modeling method is different, as I said, in cost effectiveness, you want to know the change in cost divided by change in effect, whatever intervention that you did. So the modeling method is very different there. And heteroscedasticity is important there too. If it's there, then it violates the assumption of CEA. But I can go in more detail how CEA done. In general, in CEA, we do, actually, it relies a lot on linear assumption, linear regression, instead of GLM. You can do GLM there to take care of your heteroscedasticity part. But in general, what people do is that change in cost, put as the dependent variable, and do the linear regression. Change in effect, the intervention, and then do the linear regression. And they both require heteroscedasticity assumption to be not homoscedasticity assumption to be there. They don't want heteroscedasticity.
Okay, there is
So
another question.
yeah,
Sunny Anand says, Sir, interval variable can be replaced from nominal variable.
interval variable, I think he means.
Interval, yeah,
And
interval.
interval, what is the interval variable here? For example, any variable for age is an interval, like, um, um, in general, if I am understanding the question correctly, he or she person is saying that can interval variable change to nominal? It means that when you have age on the right side, can you make it like 18 to 24 one age group, 24 to 34 another age group, 34 to 44 another age group, that kind of thing? The answer is yes, you can do that. You can consider that and make it as a nominal. But that would, when you put that in the right hand side, I assume you want to put it in the right hand side. Then if you put it like 1, 2, 3, 4, 18 to 24, 1, 24 to 34, 2, that would give you different effect. But if you put them as a dummy variable, like 18 to 24, 1, otherwise, if the person is from other age group, 0, 24 to 34, 1, if person is from other age group, then 0. I think modeling that way would be better because then you'd get the cost estimate separately for each age group. 18 to 24 is is modeled 1, and anyone else coming from any other age group is modeled as 0. Then you will have another variable, x variable, in which 24 to 34 will have a value of 1. Anybody falling in any other age group will have a value of 0. I think modeling that way will give you more bang for the buck because then you can explain what was the cost for each age group.
Okay, I think we are done with the question. So, Dr. Ashutosh, please continue.
Yeah. So now going ahead that we have addressed the problem of GLM, uh, of the OLS using GLM. And these are the advantages. If you want to do it in your real life, you can use Stata here to do the GLM. You can also use SAS. These are the GLM advantages that we discussed. GLM link function that we discussed. There is a method called boxcox method. There has been some development in this method. A Stata command is also there, boxcox. I have used it in my own research. So you remember in the GLM, first part was a link function. And how would you know if it needs a log link or other link? So that's that's where to know the identify the link, you do the boxcox regression. So I'm not gonna go in detail. You can read about it later on your own if you want to. But what it basically does is that it takes your dependent variable, which is the cost, left side variable, and puts all the independent variable on the right side. And then it basically tries to model this way. The cost is your dependent variable, and this tries to find the theta. So basically, it's modeling the relationship between your independent variable that you have already. You know that these are the variables you're going to put in your model, and this is your dependent variable, and it gives you a value of theta. Depending on this value of theta, you decide the link function that you're going to use the log link function or the square link function or what kind of link function, depending on what the value of theta is. So people use this. In my paper, I also use this to verify that it was a log link function, depending on the value of theta and what theta value defines what. So here are common examples of log of link function in GLM. You can take the inverse, in which your dependent variable become 1 over cost, and this is called inverse link function. If you just take the log cost, which is what we discussed in this training most of the time, log link function, you will take the log when your theta value is 0. So many a times when you do the box-Cox regression, it's called box-Cox regression of your dependent variable based on independent variable, you will find it will it will spit out these kinds of values when you run the regression of theta. And depending on the value of theta, you choose the link function. So you are not basically assuming anything. You are letting your data tell you what link function is the best for this data set. So most of the time, more often than not, you will find your theta value is closer to 0 than 0.5 or -1. It is around 0 most of the time. And that's why people take log. But if you have a data in which you are getting different kind of theta value, then you can choose, you are free to choose any of these link functions in your GLM. And then this is for advanced. People have done, I have done in my paper too. I am not going to go in detail, but this test is very famous. Many healthcare cost papers have used this modified POC test, they call it. Basically, this is to know if I want to use the gamma. So there was, I think, a question from the audience, why use gamma? Well, you don't have to use the gamma. You can basically do this test, and then it will tell you if gamma is suitable in your model or not. And what it does is that it takes the GLM regression first of the log link and residual, squares the residual, and then do the second regression, which is simple linear regression, and do this regression. And from this regression, it models the family. So basically, you are you are verifying that your gamma distribution modeling assumption is true. And then there is a statistical test to verify that your assumption is true. And using this assumption, then you will use the gamma distribution. And how would you do the gamma distribution? You will find that when you do the modified POC test, you will find it will give you these different values of gamma 1. So this is the parameter of interest, which you want to know. When you regress this, so there is a method how to do it. I am not sharing the codes here, but this is the math that you have a GLM regression, and this is an estimated GLM regression, and you subtract it, and then you take the square of the residual, which is the error term, and then you run it again on independent variable predicted by. And then you want to know the what is the value of this guy, the gamma 1. And depending on the value of gamma 1, you decide what distribution you will use. So if it's 0, actually your data is normal. And if it's 0, then basically you do not have heteroscedasticity to begin with. So your cost data was already very good. You could basically, if it was 0, you could basically do the regression, simple linear regression, and run with it. Like, that's your model. If it gives you value of 1, then it's preferred to use Poisson regression, because Poisson considers that square of the error is proportional to the mean, directly proportional. Mean is directly proportional to the variance, so it's the relationship is 1. If it's 2, because gamma distribution assume that a square is directly proportional, a square of mean is directly proportional to the variance, and that's why we use the gamma. In my current examples, in my papers that I have worked, I mostly found the value to be around 1.8, 1.9. It means you need to do the gamma. In some cases, it goes like, 2.4, 2.5 also, still people. So basically, if this value is coming between 1.5 to 2.5, you stick with gamma. And then, if there is something else, then you choose. Many times what people do is that they change the distribution assumption and look at their estimate, if it changes or not. If your estimates are robust, like even if you're choosing Poisson and your cost estimates are still the same, you report both in the paper, but you put Poisson regression in the appendix and put the gamma regression in your main estimate. Report the main paper using the gamma. So there are many other models with the skewed data. There are like, Dr. Basu, who is in University of Washington, he has written a lot of paper in health economics. Um, and then, he has done it. So if they have more questions, since we already discussed it, so no more questions. We discussed heteroscedasticity, we discussed GLA models. What what needs to be done when there are multiple zero values? So GLM took care of our variance problem, right? We did not do log only. GLM model took care of that variance problem that we had. It was not a constant variance. But if we still have healthcare data in which people have visited clinics, but they had zero cost, because some people visited, maybe, they didn't have any cost. Everything was covered by insurance, and you want to estimate the cost. Or people just didn't visit, but they are in your data set. You do not want to drop them, because once you drop them, then it becomes your sample is only for sick people. It does not include any healthy people. So what do you do when you have tons of zero values? For that, in cost papers, people have done this two-part modeling, and it's a very nice way of doing it. So what you do is that you do two types of regression. One regression is when you just include the people who have incurred any kind of cost, and then you do logistic regression, in which basically you predict the logistic regression predicts the probability of having positive cost. And the output of that logistic regression, you use that to model another GLM. And then basically, you did not drop the sample of people who were healthy and did not visit clinic with zero cost. You use their probability of having use the full sample to estimate the probability of having positive cost, and that probability you used in your GLM model as the weight, statistical weight, and that's how you accounted for it. And that's they call it as a two-part model. And this is how it happens. Two-part model in which you regress, you estimate first step is that you regress this, in which this is the part one, in which you model the probability of y, which is the cost, greater than zero, first step, in which the probability that y is greater than zero, conditional on x. This you can do from logistic regression or probit model, logit or probit model, anything. And and then the second step is your standard GLM you can do, or even regression you can do, but we know that we are not going to do the regression. Um, we are already doing GLM. So you can do the GLM. So this is how it happens. Expected value of y, conditional on y being greater than zero, conditional on x. So you feed this first step in the second step. So you add one more step, and then you estimate the cost. So when you do the predicted cost in two-part model, this is what happens. You have two parts. First part this, conditional on x, and then you multiply this probability. This is the probability estimated in first model, and you multiply this with the regression equation in the second model, and in the overall you get this estimate, which is what you wanted, expectation of y given x. And this is the logistic regression mathematical notation. This is the easiest way to remember logistic regression. I used to remember log p over 1 minus p. P is the probability of cost being greater than zero. And so you basically take the log of people who had, um, you know, greater than zero cost. And so you would have, for example, if you had 20% of the data with people had zero cost, then p value will be 0.2. And this value will be 0.2. So you divide 0.2 divided by 1 minus 0.8. And basically you do that log 0.2 divided by 1, 0.1 and 8, and then you model for each one of them. This was just a rough example. It's not exactly true, but I'm giving you intuition that this is what it models. So basically you are estimating log odds of having positive cost in the first step, and then you will feed in your second model. So logistic regression you can do in SAS. Logistic regression in Stata is simple. Just use logit, and this is the remember in the logistic regression you are just using people who had positive cost, and you will find out this. Well, you are having using the full data. You are using the full data, and you are then feeding in here to predict the probability of positive cost. So you're not dropping anyone from your data. You're not dropping people with zero cost. You included everyone and then predicted this. And this is where you get probability in the second step. And the moment you know the probability of positive cost, then you multiply in the second step, which is the second part. And then you can use GLM or OLS. But you know that we are not using OLS as much. You can use the GLM is preferred. Does anyone, did it become too complicated? Anyone has questions? Then if not, then I'll go ahead.
Yeah, there are a few questions for you, Ashu. So maybe I would like you to respond to that before you proceed ahead. Okay, so I'll start with the first one. Rasmika Inampuri is asking, sir, how does box Cox transformation handle zero and negative values in data?
Oh, yeah. So the box Cox does not take into account zero and negative from, value. Yeah. Well, the good news is that cost value is never negative, as we discussed very much in the beginning. So when you are modeling cost, you don't go to the clinic and the doctor pays you money. You pay the doctor. So that doesn't happen. It's never negative. Zero cost is there. Box cost doesn't do it. And that's why you are using this. That's why you are using not using boxcox for zero cost. You're using two-part modeling for zero cost. In the first part, you just get the probability. So whenever you do the boxcox, you have to get rid of your zero observations. Uh, the cost dependent variable cannot be zero. Um, you need to have a positive value. So yeah.
Okay. Next one by Jusu Musa from Sierra Leone. He's asking, when should we use a log link versus an identity or inverse link? Otherwise, thank you so much, Doc. You really put me on today. Okay.
So when should we use the log link or the identity link?
Yeah. Or inverse
Yeah.
link.
Yeah. So for that, we discussed that. So sorry, I'm going ahead. So we are still in this was about the GLM, and to know the link function, you do the boxcox, and when you run this boxcox regression, somebody has very well pointed out your y value has to be greater than zero. Remember, the cost cannot be negative or the zero. The moment you get the non-zero positive cost, you'll get the value of theta. You run the regression basic way. This is the boxcox command. What it does is that basically it's regressing this. When you do this boxcox regression, it's regressing the cost value multiplied by theta, and it runs multiple iterations in the background. Stata does it for you in one step. You just type this command, and Stata will do it for you. But in background, what's happening is that for different value of theta, it's running this regression. And then a Stata will give out. In general, for every theta value, you will run this regression, and you will find out what is the value of theta. And based on that value of theta, you will decide which link function to use. In my case, I have found whenever I have modeled the cost data set, I have found theta value to be closer to zero. And you will never got equal to zero. It will be closer to zero. And then you will just use the log function.
Right. Okay, there is another question from Santa Kumar Aritos. He is asking, what type of response variable distribution would you use a generalized linear model GLM with a logic link function for? This
What
question
kind of
would help assess understanding of GLM and its application, he is saying.
What kind of response variable?
Yeah, response variable distribution would you use a generalized linear model with a logic link function for?
Yeah, so the logic link, if I understand the question correctly, the logic link response variable is the right hand side, right? Your independent variables, right? And if you can use anything, it's independent of what you put in the right hand side. This is only about the logic link that you are choosing. It's only for your cost variable, which is on the left side, which is what you wanna estimate. But if your question is about left side variable, then first you have to know that why you are doing this exercise. First, you need to know if you have a response variable, if you consider that you are estimating something. For example, somebody had asked about ordinal variables. For ordinal variables, none of this is going to work. They have a different way of estimation. For any other response variable which does not have a skewed feature like cost data, which does not have those problems, many a times when you will read papers, you will find people have just done linear regression. Why? Because they did not have those kinds of problems. High value of zero and highly skewed. If you have a response variable, which I believe if you need to know, the predictor estimate, then you don't need to do this. It's more applicable for cost and these kinds of things. But in general, GLM has been used very widely in medical field, at least. GLM is like very highly used because of these features. And then whenever you see that GLM is being used, then you have to kind of do this.
Okay. I think you have answered most of the questions. There are a few more left, but just to be mindful of the time, Dr. Kumar is not here for the entire night, as per his time zone, the entire day. So let's use the time more effectively. Let Dr. Kumar complete his presentation first, then you can ask more questions. Okay? Yeah. there will be a dedicated question and answer around as well. Thank you. Please continue.
Yeah, yeah. So I already discussed many of this. I know this is a bit more technical, but these are very useful. You can basically go about writing a paper on cost data tomorrow if you understand all of this. So it's done. You know, in the first part of this lecture, we discussed how to take care of heteroscedasticity. We use the GLM model. In second part, we are discussing how to take care of all those zero values in which people had health insurance, but they never visited healthcare and they had zero cost, which is the real world. A lot of people are very healthy, they have no cost. And you are not trying to drop them from your sample. You want to keep them. And you want to keep them how? In the first part, you estimate the probability of them having any cost. And then in the second part, you do the regular GLM in which you multiply that with the probability. And that's what we are doing here. You estimated this in the first step, and then you multiplied this in your second step with a regression equation. All right. So we discussed this. This is what you model. This is simple logistic regression that we do. Here your dependent variable has 1, 0, 1, 0, in which 1 is for those people who have positive cost and 0 for those people who had zero cost. And then you model. So your dependent variable has only two outcomes, 1 and 0. And then you model this logistic regression in which you will get the probability. And then in the second step, you multiply this. This is a SAS function which you can use. Logistic regression syntax in Stata, it's very simple. Stata just use logit, and this is your cost function, cost variable, and model it. In general, whatever you will use in the GLM, in the next step, I put the same independent variable here. For example, if you're putting sex, age group, everything, income, whatever you can find, which you think has. So first, when you put the regression equation, first you need to know from the medical field and the literature that what variable do you want to put in the right-hand side. It's called kitchen sink model. When you start putting like 20, 30 variables, anything, whatever comes in your mind, and you start putting them there. So you don't want to do that kitchen sink. You find out what are the variables that are important for estimating cost, and what kind of those variables that can predict those things. And once you decide those variables like sex, age group, income, demography, other types of demography you can use even the interaction. You put everything in here, do the logistic regression in the first step, find out the probabilities. This will give you the probabilities between 0 to 1. And the moment you got it, then you will do the GLM or OLS with log cost, but you don't need to do that. As we know, this is inferior model. But in case, your modeling is giving you that you can do OLS, you can do OLS. And that's how the two-part model is done. So two-part models here, you can do, like, it has two part, independent variables predict participation. So in the first step, you first basically took care of people who were deciding to participate, basically who were deciding to stay in healthcare, get the healthcare. In the second part, you multiply the quantity with the probability, which I mentioned. So two-part model command, the Stata command is very simple. As I explained, I do more Stata than SAS and R. So you can use this in your two-part model. And there is a very famous Stata command, which was given by some professors who include, so you don't even have to do anything, basically. These are the things just use TPM command, and this is your cost variable. This is your independent variables, sex, age group, and everything that you wanted to put. And then in the first one, you will define that in the two-part model, this is your first part in which you are doing the logistic regression. Here you can also mention probit model if you want to do the probit. And in the second part, you are telling the Stata to, once you get the probabilities from the first step, multiply this probability in the GLM model, and then you will define the GLM model family gamma link log. And what the Stata will do for you is that it will multiply the probability and give you the final product. with the GLM, and then you will have the cost estimate. You can get the cost estimate by sex, by age group, and this is what is used overall the world whenever they're estimating any kind of economic burden of illness or any kind of cost, healthcare cost. So yeah, this is how TPM command works. Out of sample predictions, you can do. So if people are no regression, they know that we want to do the out of sample prediction. Then Stata has some features in which you can do out of sample prediction. Generally, we use the margins command, and Stata also has some kind of retransformation, which I'm not very fond of. We are not taking log and then removing the log, so we are not doing any kind of. But the Stata has a feature to do those things. There are a lot of people who don't want to do the two part, which I don't understand why. But if you want to avoid two part model, then you can do basic OLS with untransformed cost, which we know that is inferior. It's not good model. You can do OLS with log cost, which it takes care of normality, it takes care of the error variance, but still uh, it doesn't take care of zero cost. And some people, what they have done, there is another method which some people do. I have done it, but I did not include in my paper. That people who have zero cost, you change it from $0 to $1, and then take the log. And when you take the 0 to 1, and when you take the log of 1 is 0. So you can still do the modeling, but those people will not be dropped from your sample. So some people, what they do, they increase the value by 1. Again, the whole sample, they increase the value of by $1. Because if you increase the cost by $1, it's not going to change your data set much because you just increase by $1, right? So some people do that, but again, I would consider that as inferior. Every other model I consider inferior to two-part model for estimating cost when you think of it, because two-part is completely fully packed, takes care of both the error and the zero value. And this is where I was discussing about the example. So this was the first paper that I did, uh, that I wrote here in CDC. And as you can assume here, this paper, this was published back in 23 in JAMA Pediatrics, and we had sample of children, 2 to 19-year-old children. Here I'm giving you a real world example. Some questions were asked to me. And what happened is that we had 2 to 19-year-old children from all across US, and we had their healthcare data. And we were estimating that what was the effect of their body mass index, in which some children were underweight. Body mass index, if people know that it's measure of underweight or obesity or overweight or healthy weight. So you have a variable in which you know the children's weight status. Either they are underweight, uh, overweight, healthy weight, or obese, like with obesity or severe obesity. So there are 5 levels. And we are trying to estimate the cost of healthcare for all these children. And we had about 200,000 sample, 200,000 kids. And, it was very highly skewed. You would find that children with severe obesity and underweight had really high cost. But when you try to model, it's a very different exercise. And then we had to do everything that I mentioned to you, like everything. And thankfully, JAMA Pediatrics, they liked our paper and it was published. And this was also kind of paper was nominated inside CDC for for an award. So these are some real examples lives that I did myself. Now, this was about BMI and cost. I will basically I will share the screen, and for students' benefit, I will discuss the paper a bit more. Today was less about my paper, more about the method. So
Sure,
I
sure.
can go and
Please.
discuss Since
Yeah.
paper asked about the questions, I will discuss more the papers and finish this
Yeah.
presentation.
Yes.
And
Sure.
this is a second paper that I worked inside CDC, but this was in the first division in which we worked on BMI and medical expenditure. Uh, This was children, age 2 to 19-year-old children. This is the second paper in which I worked on adult data set. And this is not about BMI. This is not about obesity or anything. This is about hypertension, blood pressure. And these are some of the results that we got from the paper. And this is the real life example of a paper that this was published in Hypertension Journal, which is one of the top journals of American Heart Association. And they people want to know that how much does hypertension cost? And you would be amazed to know that hypertension for inpatient cost, outpatient cost, and pharmacy. So how much people paid for prescription, how much people paid for outpatient, like when they visited healthcare for a single visit without hospitalization. And in this one, if they were hospitalized, how much did people pay? And my estimates, and overall is about $3,000. So, so you would be amazed to know this paper. What is this paper is telling you is that on an average, uh, people with blood pressure pay $3,000 um, higher than those people without blood pressure annually in the US. It costs $3,000 extra if you compare people with blood pressure to those without blood pressure. And their costs are higher by $1,000 in their medical prescription, like pills, uh, $2,000 higher in their outpatient visits, in which they have to go to hospitals few times, and about $3,000 higher for inpatients. So if people with blood pressure get hospitalized, they kind of pay up $3,000 more than those people who get hospitalized without blood pressure. So it's comparing levels at two levels. First, it's comparing people with blood pressure without blood pressure, and then it's comparing people who get hospitalized with blood pressure with those people who get hospitalized without blood pressure. So in this method, you have everyone who got hospitalized, but those who got hospitalized without blood pressure, they had to pay a little bit less. So now this real life implication of this paper is that now the government and a medical practitioner or healthcare clinics, everybody knows that if people with blood pressure just visit the hospital and somehow they get hospitalized for some conditions, these are the cost. And as we all know, hypertension is something that we all can prevent. Hypertension is preventable by doing physical activity, you can take care of your blood pressure yourself. So if you do not have blood pressure, you would save these costs directly. And government and medical practitioners, everybody want to know. And that's why estimating cost is important. Another outcome which was added in this paper was that hypertension in general was very expensive, but hypertension is very bad for women than men. Uh, in fact, if you find the US or in fact across the world, hypertension is highly prevalent among men. Higher percentage of men throughout the world, in any country, if you go pick, including US, there is higher percentage of men who have high blood pressure problem than women, percentage wise. But what this paper contributed is that although the prevalence is higher among men, but the costs are higher among women. So hypertension is more expensive to healthcare and for those people who have hypertension among women than men. So if women have hypertension, even though prevalence is low, but the costs are high. So it means high blood pressure has higher complications among women. And you can see that inpatient, we didn't find any difference between men and women, but outpatient, we find that women were paying about $900 higher than men who had hypertension compared to women who had hypertension. So in this, again, I'm comparing two levels, men and women with hypertension. So my sample, everybody had hypertension, and I compared them, and the women paid more. Pharmacy, they paid about $800 more in pills, pharmacy like prescriptions. And age group we did not find. So if you had age hypertension in any age group, you cannot, statistically, they were not significant. All ages had hypertension with age group we did not find any effect. And this is the kind of and now we can see these are your X variable that you put in the right hand side. Different age groups, different age bands, estimated the cost estimate of hypertension. If you find this age group was paying highest cost for hypertension was in this age group. And you can believe this is youngest age group, college going, 18 to 34. Cost is very high, but it was not statistically significant. As you can see, the lower interval is here. So we could not say that age was a predictor. But this was also came as a surprise to us that why this age group had highest cost. And again, remember, here we are comparing in this age group those who had hypertension with those who did not have hypertension. And we found those who had hypertension, they ended up paying $3,500 more in healthcare than those who did not. And then overall, you can see there is no statistical significant effect. But for men and women, there was significant effect. Men, of those with hypertension, they paid only $2,500 more than women. Men, those with hypertension paid $2,500 compared to those without hypertension. Women paid $3,200 among women. And then the difference is, $700. So on an average, women paid about $700 more in hypertension. So these are the all beautiful things you can do by just running the cost analysis. And these kinds of analysis inform government, medical practitioner, hospitals, everything. And that's the end of this presentation. If you want to learn more about these papers, I can go to the website where these papers are published, and I can discuss some aspect of these papers if people have questions. Otherwise, these are just a review of the presentation that, cost is, these are the things we discussed, what you can do, and yeah. But otherwise, this is all presentation. And these are some of the papers that you can study, which are very highly technical and very statistically and economic, very advanced method. But if you're still curious, you can read about all these things in these papers. Another thing that I want to point out is that some of the slide content that I have created, I have been benefited from cyber seminars that they do. Another people, I have been attending their seminars. When I was graduate students, I used to attend their seminars. That's good also for the students if they want to go visit their seminars. These are VA seminars, which is Veteran Affairs of the US. They attend, they have some free seminars. So yeah, that's all.
Okay,
I don't think I went over. Yeah.
Okay, what a wonderful presentation. Yeah, please, relax now because you have already taught a lot of things. I think our participants who are here, their numbers have suddenly increased because they are going to receive the attendance link just now. So they are very geared for that. Some of them had dropped out. Now they have come back. So you're monitoring that as well. So the attendance link will be shared just in 5 minutes. So please stay tuned. Do not go away anywhere. If you want to receive your special training certificate, okay, from the Global Consortium of Global Health as well as Bangladesh Institute of Innovative Health Research, signed by both me and Dr. Ashutosh Kumar, then please stay tuned because in just 4 minutes time, the attendance link will be shared in the chat. Okay, so do not go away anywhere. That's the first announcement. Second, coming to you, Ashutosh, it's been a wonderful presentation. I think I have learned so much in this lecture itself. It's been wonderful. In fact, the kind of questions which participants are asking in the this particular chat function, question Q&A, are also interesting. Some of them have been already answered, so we have marked them as answered. So there are a few more questions are left. Now we'll open the floor for the participants to ask questions for the next 18 minutes to ask questions and benefit from your wisdom. In the meantime, let me start. Those who want to ask question, you can either put the question in the Q&A or Hazel, please allow participant to speak, but you do not speak out of the turn. Please raise your hand. We'll allow you to speak. Okay. Yeah, that's the way. Faisal, is that okay?
Yes, sir. They can raise their hands. I can give them the access.
You can unmute them. Yes, that's the process. Right. Okay, so let me read out the question for you. Arindam Vishwas is asking, sir, could you please give an example of how a particular health econ study helped design any kind of policies for obesity treatment or drugs? That's the first question.
Yes, very good question. Very, very smart and very nice question. So in the US, childhood obesity is a very big problem. And can I share my screen? All right, I
Yes,
can
please
go
go ahead.
share the screen and then you will
You are the
know
boss.
what I'm talking.
You are the boss today.
Yeah. So I'm gonna share the screen, and this is very pertinent question and very beautiful question. And I'm gonna, I don't know. Yeah, this is the screen I think I should share. Yeah, share. So now I'm instead of sharing my slide, now I'm sharing a screen. You all can see this paper where I'm on the website, right?
Yes.
Dr. Satpathy, that's the correct, right? I
Yes.
just want to make sure that
Yes.
I'm sharing the correct
Perfect.
screen. Yeah. So this was the
Yes.
paper you can see here. In this paper, you can go. I think now it's for free. And in this paper, I cited some of the papers in which some Harvard public health and econ folks published a paper in which interventions about the interventions and what they found is that there have been multiple interventions for childhood obesity in the US, and they don't know which intervention worked. This is the paper I am talking. So, these three interventions that reduce childhood obesity are projected to save more than they cost to implement. So, these papers, um, can everybody can see the screen, right? So, this paper, what they did is that they looked at all the intervention that government was doing. You can go and read this paper. This Gottmaker guy, he's in Harvard and one of the most famous for childhood obesity in the US. His papers have been there, and they found only three interventions are helpful, which I'm highlighting here. Right? They found that only three interventions were cost effective. Means they are saving more than they are cost to implement. As you all know, especially in developing countries, we have multiple interventions by the government to tackle some kind of problems in the society. And the governments want to know that if I'm doing spending like this much value, this much money for particular intervention, how much money it is saving. Because if you're putting like $200,000 for a project, and if it's saving you only $50,000, you are losing $150,000 in between. So they did the same thing. And many of these cost papers, they give you an estimate of the cost, what happens. Like in this paper, I gave the estimate, and and you can see that these are the estimates who were there: underweight, overweight, moderate obesity, and severe obesity. Costs are very high. So these estimates, it means they know that on an average, very high obesity costs $950 for a child. If the child has obesity, they end up paying more than $900 in healthcare. And using those estimates, they found that only three interventions: excise tax, elimination of tax reduction, and nutritional standards of food and beverages sold in a school. Only these three interventions were cost effective. Other four interventions, they were basically saving less than costing more. So this is the real world example that Arindam asked, right? I think Arindam was the name. This is the real
Yes.
life example in which US government has seven different policies across the US, seven interventions. And they found that only these three: excise tax, it means you put some tax on beverages. That's the exciter. Like, the Coke, if you sell Coke, children here drink a lot of Coke and Pepsi and all. And they try to, because Coke and Pepsi they are notorious for having too much sugar, and sugar increases, chances for obesity. So, so they tried to put some taxes on Coke and sugar so that people would buy less. So that worked. Elimination of tax reduction, nutrition, and they also did some tax reduction, some tax benefit they were doing for some other uh, products that also saved. And nutritional standards here also in schools in the US, they give foods and beverages. They started doing some standards, nutritional standards, and these were less cost to implement. but they were saving more because there were less children with obesity. So that's the answer.
Okay. Okay, there are many more questions asked for you, so I just have to be very quick because we have less time left. If anybody wants to ask question directly, you can raise your hand and we'll allow you to unmute yourself and ask questions. And the attendance form has been shared in the chat, so please check it. It's only allowed for 15 minutes. Please fill the form if you want to receive your training certificate. Okay, so the next question is Alasana Sise. She asks, how do we test whether a GLM is correctly specified for skewed cost data in health economics?
Yeah. So as you saw in the training, I discussed that first you want to know the cost variable. First thing you will do the moment you get the cost variable, you run a histogram of your dependent variable. And if it's a skewed, like too many people in zero cost and then very high and then it plateaus, then you have it's a perfect model for. I probably might have some in this one. So I might have modeled it here. So these are the supplement files and all the regression equations that I added. But no, I did not model the cost. So it's a very basic modeling exercise in which you first model and you see if it's very skewed. It has all those features, a lot of zero values, very skewed. It's perfect for GLM. And the moment you do the GLM thing, you do the two tests that we discussed in the training. First, you do the link test, box Cox, and then you do the link test, which is modified park test. Using those two tests, you can know that Boxcox will tell you if it's suitable for log link or not, and modified park test will tell you if the gamma is suitable or not.
Right. Okay, the next one is Basar asks, yes, sir, what method is preferred in modeling for dependent variable with interval?
Dependent variable with interval. Yeah, so interval means I again assume that you mean like 18 to 24 one age group and 34 to 44 another age group. So yeah, so it's a so in those kinds of cases, the modeling exercise will be different. But if you're just using the continuous variable, uh, which you mean by the interval, then you can just model like uh, any other regression equation. So I don't fully understand that what dependent variable with interval means. If it's just a continuous variable, you can just do the basic regression, OLS. And if it does not have those problems like the cost data. But if it has a problem like cost data, then you do the GLM.
So it depends on the nature
And
of
if it
the
has a
data
lot of
form, isn't it?
zeros, huh?
It depends on the nature of the data form.
Nature of the data,
Kind of model.
exactly. It depends on the nature. Yeah, if it's an ordinal data, there is a different statistical method for that. If it's different data, different recipe.
Definitely. Okay, the next question to you comes from Vishnu Priya Iyer. If anybody wants to ask question, you can put it in the chat or in the question Q&A. Okay, do not miss this chance to ask to Dr. Ashutosh Kumar your questions, okay? Because we still have 10 minutes and you can use the time to ask questions. There are a few more questions which are pending. I'm going to read out one after another. Sir, any open source software for health economic studies? Asked by Vishnu Priya Iyer.
Yes, very good question. Yes, you don't have to pay for Stata, you don't have to pay for SaaS. You can do everything that we talked today in R. R is open source free software. There are codes freely available. If you're doing, for example, cost analysis, do a Google search, put
Can you
GLM,
please
cost
demonstrate them
data.
maybe for a minute or
Yeah,
two? Is
so
that possible?
there is so much training material available. I can also go and do that for you. Like I can, but so GLM cost in R. Like just do this. R is free software. Now because of the chat GPT and everything, it will write the code for you. But you have to verify the code. That's where you need some expertise. So yeah, so basically this I know the code, like this is your in GLM you can do in R. Cost is your dependent variable function, and then you can do this. Here it is, but you can also find I generally when I do that myself, I go to some university website and professor's website because it's verified. And it's not like some random dude writing on net, on website and you are picking it from there like Substack or Reddit. So somebody who's professor, sometimes many professors put their like this is the perfect website where professors are putting their papers and this one is actually ours GLM package. And so you can do that many a times. So yeah, this is what research is about. You are a student, so you want to apply these methods, and then you can reach out to your professors and know if it's done correctly. Somebody who has some kind of stats knowledge, you verify your model with them. And this is cv.glm function in R. And here, like this guy has done, this is Geeks for Geeks, and they are also not very wrong. Like many a times they do right, but they don't go like in depth like we discussed today. Like many a times they don't. They will just give you GLM linear regression function, and many a times they give you like this is the GLM code for binomial
Right.
link. Today we
Right.
discussed gamma link. You can use this. So to get the code, it's easy. But that's why I know getting the code is easy. Getting the math or why you are doing what you are doing is more important. And that's what I was focusing today, not the codes and everything.
So you need to have the reasoning, the right reasoning.
Yes,
Otherwise, I think
right
anything
reasoning.
else is
Otherwise, you will write the code, you will get the code from website anywhere, but you don't know what you are doing.
right. Correct. Okay. The next question comes is which modeling? Basar asks which modeling is preferred for dependent variable with ordinal scale.
Yeah, so the dependent variable depends on that. Today I told you about OLogit, ordinal logistic regression. There was one paper in which I was working on, in which you have the dependent variable, in which it's highly people have been asked like, how do you rate your health? And some people said good, some people said bad, very bad, some people said very good, some people said excellent. Health status. So 5 levels. It's an ordinal dependent variable. So when you try to model those kinds of dependent variable, you have 5 values in the left hand side. 1, 2, 3, 4, 5. And it's not cost data or something like that. And for that, there is a different modeling method. If you want to know the probability of people being in each group, then you do the ordinal logistic regression. If you want to know the, depending on what you want to estimate, most of the time people use the ordinal logistic regression to know the probability. Some people want to know the change in probability in moving across from one stage to another stage, from bad to very bad health, or from good to very good health. People use different methods. Yeah, depending on question, what you want to do. You can also do the regression,
Definitely.
but that would not be very wise.
True. They're all learning and they're catching up. I think they're going to do very
Yeah.
well now that you have trained them. The next question comes from Santa Kumar Aridos. They ask how Bayesian approach may help in GLM model for fixing the model parameters.
Yeah, so the Bayesian approach is needed when you don't have, in general, people use Bayesian when they don't have some of the parameters is very like data you don't have. For example, Bayesian people use, say, you're modeling some cost data, but you have data for some small town, small rural village, where you have only 5 people, and you want to make sure that you include them in your model. And when you don't have data, then you use the Bayesian for those kinds of estimates because you just don't have the data and you cannot estimate. Those are the only places where you can use the Bayesian. And the modeling approach is same later, but the Bayesian approach is first to get the data for rare occurrences, rare samples. So that's the way you can do the Bayesian, first
Okay.
step. And then you do the basic GLM.
Okay. The last
I have
question.
not, but that's the question. I have not researched Bayesian and GLM mix. So that's why I cannot fully answer the question. I have not done it myself.
That's
Yeah.
fine. They'll learn. You will learn. I will learn. Everyone is learning. That's fine. Okay. The last question to you is actually very interesting because that's the kind of thing that we are doing here. We have learners across different career trajectories with different learning needs as well as learning attendance. Backgrounds. So therefore, we can Let me ask this question on behalf of Dr. Firdaus Samad. She asks, good evening, sir. I'm an MPH student in India. I had been taught health economics during the third semester. However, I could not grab much out of it. I'm interested in pursuing a career in health economics outcome research. Where should I begin from? Any course recommendation or any career guidance? My background is in dentistry.
Yeah, very good question. And what you can do is that here is a very wide field. Let me give you some basic. I am not exactly in here, fully here, but here is a very wide field. It includes pharmacists, very predominantly, people who have B Farm, M Farm, and Farm D, and they are highly represented in here group. People from public health are highly represented in here. People from medical schools are very much represented in here. Here has only one aspect of economics in between, HE, health economics, but it has very less representation of standard economists. I am a standard, I am taught in economics. I was never taught in here. I have in When I did my PhD in economics, health economics was my field. And I pursued and became a here kind of like I liked here what they were doing, but I must still call myself a standard economist. So to pursue here, you have to first gain some knowledge about certain health economics courses, which are widely available. In India, also, there are a lot of health economics courses. Courses in health economics. Courses in economics, traditional economics is very different. They teach health economics differently. But health economics taught by medical school is the best. You go there. There might be some economists giving those trainings. So, for example, all these professors that I gave you, they are either in medical schools or pharmacy school of pharmacy. They are doing it. So you go pursue those courses, one or two courses, and then mm, try replicating some of the research that professors have published uh, from publicly available data. So try doing some of the analysis from publicly available data. In public, if you want to do save some costs, then you can use R instead of Stata and all, and try do some analysis. Work with some professors in India who have some publications in here, outcome research, and who have some statistical. Yeah, take some courses from a stats department too, if you can. Fundamental stats is very important, especially in these days. I think everybody needs to know stats. AI and all, like it's coming and taking over. They are all based in hardcore statistical foundations. So if you go and take courses from a stats department as much as you can, sometimes theory is helpful. Having theory, it gives you more fun and depth. But if you can get theory, at least get some application courses. Because theory is not every theory requires a lot of deeper mathematical understanding. That's theory. But if you think you lack them, then at least go and do some application courses in which they touch upon the methods and models without going mathematical details.
Okay, okay. The last question is a very interesting question. Okay, by Dr. Malavika. She asks, "Sir, how can we combine yoga and health economics?"
Yes, very good question. So there is a department in NIH in the US, and they call it Department of Alternate. I don't know if they're still alive or not because as the President Trump has kind of reduced a lot of funding for a lot of these organizations, and they are called Department of NIH, Department of Alternative Medicine, and they included these yoga alternative medicines. They include yoga and many Ayurveda and a lot of things. So, the answer to your question is that yes, you can do that. So, you just need to know a data set in which there are people who have had healthcare visits and and they have reported if they do some physical exercise in which yoga is there. And then what you can do is that you can know the impact of yoga. That's a very good question because some people have done some kind of research, especially that department. They have done some publications in alternative medicines, which are not purely medical, mm, pharmacy medicines, and they have no they have tried to know the cost uh, saved because of those alternative methods. So people, what you would do, you would compare same GLM model you could do. I gave you a tool which you can use anywhere. You would use the same GLM model in which you will compare those people who did yoga with those people who did not do yoga. And they all had similar basic feature. Uh, like you want to make sure that your comparison is apple to apple, not apple to oranges. So you can compare a sick person who was doing yoga with a healthy person who was not doing yoga. And then that would give you, that's a confounder model. So you want to make sure when you, and then you will know that, yoga people had less cost, healthcare cost because they were doing yoga. And, uh, and that's the one way you can mix it. And there are some papers which have been done before already.
Maybe combine meditation along with yoga as well, not just yoga.
Yeah. So yeah, anything, Ayurveda, meditation, yoga, mental health is very important. People do not understand it, but mental health is it's one of the key ingredients of a very good physical health. So mental health is very good to focus on.
Definitely. And there are two more questions coming from the same person. Let me read it out to you. Uh, he's saying, do we get any online tutorial on this analysis, and kindly provide the video record of this session? Oh, a video record will be given to you. Don't worry about that, Ashwini, because it is going to be posted. But online tutorial on this analysis, I don't know. Maybe Dr. Ashutosh can answer this.
Online tutorial for this analysis. Online tutorial will be like live coding, and I share some live thing. I can make it. This one was more theory based and more like tools introductory, but still a bit advanced. Like it was mixed in between. But online, we can, if people need more training or some help, I can give you some help, some resources I can send separately, in which you can go and read about GLM and learn about it.
Okay, so Dr. Ashutosh, I cannot thank you enough for this wonderful presentation and being so patient and generous with all the questions and answering them, taking out all the time to answer them. I think our participants have benefited extremely well, and they must have learned great deal. But many of them have also come out with a request that please give the presentation slides. So I, as the organizer, would request you to please share the presentation slides as well, so that we can share with the participants in the future, and they can have, maybe they can learn a little bit. But when I'm requesting this, I am also going to request the participants that please make a fair use of that material. Do not claim it as your own presentation. If you are borrowing Dr. Ashutosh's presentation, please keep the acknowledgement every time you use it. Okay, that's called fair use. Okay. So I hope Dr. Ashutosh will oblige and will accept our request. And so that's all from my side. It was wonderful to get you on board and train our participants and pour so much of knowledge and wisdom. And this is a completely fruit of our own labor of love. We are trying to help our young emerging researchers from all over the world. We have people from more than 100 countries and more than 850 plus participants in the global cohort of our Global Advanced Certification Program in strategic collaboration and communication for young emerging researchers, which is one of a kind state-of-the-art training program offered completely for free without being funded by anyone in the entire world at the moment. So therefore, we are immensely proud of what we have been doing, and today marks the 1 month completion of this training program, and we are training our participants 24/7. It's a continuous activity happening on all virtual platforms. There are different working groups. They are all working on their research projects already. They have been approved. They are going to start working on their group projects from tomorrow onwards. Hopefully, we'll count and capitalize on some of your expertise in the future. We'll be inviting you to help us and mentor them in the future. Hopefully, you'll be generous enough in giving a little bit of time. And that's all from my side. I would request Hazel to do the necessary deals. Thank you.
Thank you very much,
Hazel,
sir.
are you there?
Thank you very much to Dr. Ashutosh Kumar, sir, as well, for your enlightening presentation and for sharing your deep expertise in health economics and outcome research. Your insights have been incredibly valuable, especially for our emerging researchers seeking to understand the intersection of data, policy, and public health impact. This session has added tremendous value to our ongoing journey in building a strategic and globally informed research community through the Global Advanced Certification Program on Strategic Research Collaboration and Communication for Emerging Researchers. To all participants, thank you for your time, engagement, and thoughtful questions. We encourage you to reflect on today's key takeaways and begin thinking about how you can apply these health, economic, and outcome research principles in your own research contexts, especially within low and middle income country settings. So let's continue this journey together toward deeper collaboration, impactful research, and leadership in global health. Thank you once again to our expert, Dr. Ashutosh Kumar sir, for your time and expertise that you have provided us, and we look forward to seeing you at our next sessions. So
Yeah,
thank you.
Thank you, Ashu. It's
yeah,
so lovely to have you. I will chat with you personally later, but for now, I think you must be very tired because you have taught 2 hours class. I had requested for
yeah,
1 hour, and you have been so deeply committed to teaching. That's what I saw today. That you took 2 hours and you didn't even realize. You know, and
yeah.
so I'm very
Time
indebted
flew.
and completely grateful to you for this. So
No
thank you.
problem. Yeah. Likewise, yeah, I like that. There's so much material available online, and if you want to learn, there is a lot of things available. If anybody has any questions, I can always answer, and reach out to me if you need any um, answer to any question. If I'll have time, I will be able to answer. I have a 9 to 5 job in which it's very hectic, but I'll give my best to answer every one of you. Thanks.
Okay, great. So
Take care. Yeah.
that's all from our
Yeah.
side. It's been a wonderful meeting. So see you all next time. Now we'll resume our leaders meeting, group leaders meeting.